Joined now by Dr. Allan Pamba, who is the Executive Vice President. It's a long title. But for Roche Africa. Good morning, Dr. Pamba.
Morning, Eric.
Good to have you on the show.
Great to be back.
Karibu tena.
Asante.
Yeah, that's a hot seat of the Situation Room.
I feel it.
Yeah. Now that you are Dr. Ricky G of Roche Africa, what does that mean?
Well, that's a huge title. I'm not sure whether it's a compliment or I'll take it as a compliment. I lead Roche Diagnostics in Africa. We are one of the leading pharmaceutical companies globally with both a pharmaceutical and a diagnostics division. We have been present in Africa for decades, and we have direct presence in Africa in 12 countries, including Kenya. I chose to be based here in Kenya. You know, when I took the role, I had the option of being based in Morocco or South Africa or Dubai, but I chose Kenya with very good reasons. I think it's in many ways a very promising country and quite central for leveraging most of Africa and entering most of Africa. So that's who I am and what I do.
Very good. When you say diagnostics, Roche Diagnostics, and it's different from Roche Pharmaceuticals, what does that mean? What do you do at diagnostics in the diagnostics division?
Right. So if you go to a hospital when you're ill, you will be seen by a doctor. And two things could happen. You could get a prescription and get treatment and disappear, go to a pharmacy and go. Or they could decide to do some tests to make a decision on what it is that your problem is. That's where we come in. When they want to do tests, then that's the spectrum of diagnostics. And it covers what will happen in a lab as we know it, where they will draw blood or draw some sample, bodily sample, and then run it through different machines. Or imaging, you know, where increasingly we have things like CT scans and so on, in our realm of diagnostics in Africa. So that whole spectrum of investigations that help the physician arrive at the right diagnosis for what needs to be treated is a space we work in. We do not do imaging, but we do all the other stuff that happens in the laboratory.
Okay.
Yeah.
You know, when you talk about diagnostics, it's a big word. One thinks of testing from a layman's perspective, but I'd like you to get granular so that we understand the diagnostics, the manufacturing of the equipment that fall under the title of diagnostics that Roche is involved in.
Right. There's a lot to unpack there, CT. I'll try and put it as simple as I can. There are broadly 4 categories of diagnostics that we manufacture, supply, and are used in facilities. The easiest and simplest to know is point of care. So if you ever had a COVID test, you know, one of these tests you buy from a pharmacy and you can administer to yourself, that will be an example of a point of care test. A point of care test is just any test that can be done by your physician right there, or you can take away and do at home, or can be run in a pharmacy. It's portable, it's very quick. So we have point of care tests. We also have what are called molecular diagnostics platforms. So molecular diagnostics are PCR tests mostly. So HIV testing, COVID testing in the lab, where they draw a sample that it disappears and then you get a result. So those are big machines that you will see in hospitals, you know. Those are the platforms that do molecular testing. Then we have what falls under the category of core labs. So this is clinical chemistry. So your lipid test, your blood sugar, your blood chemistry, you know, sodium, electrolytes, you know, in your blood, etc. And then the last category is pathology, you know, and that's simply put where you have tissue diagnosis with cancers, you know, and so on. So we have equipment that fit within all those categories, and they look different and operate differently. The beauty of what Roche does is we develop systems for laboratory, so we don't just sell you one piece. We can sell you an ecosystem that covers the spectrum of tests that you may need to do for your range of patients that you see. And the systems are high throughput, so high volumes, and they're automated. So you can get a lot of automation, which means that you can serve large populations or large volumes of patients with these systems efficiently. An example of this will have been during COVID. When COVID happened, you may have had hospitals scrambling for, there's a particular machine that does COVID tests. It does a number of tests, including HIV, but COVID was what was needed at that time. And these machines ran hundreds of tests in a day.
What are they called again?
So the one that Roche has is a core-based platform. I don't want to talk specifics because it borders on the realm of advertising, which I'm not allowed to do. So I'm going to be a bit general. Bear with me on that.
I will.
But these are huge platforms that conduct tests in high volumes. That then when you have a situation where you have huge patient volumes, you need that high volume throughput to be able to meet the need. Or when you think about this at a country level, you know.
You know, when you talk about tests at that level,
Yeah.
and you mention COVID and talk about HIV in the same breath,
Yeah.
one has to ask, what exactly is it testing? I mean, what is this thing that it tests that tells you it's COVID as opposed to being HIV,
Yeah.
as opposed to being something else?
Yeah, and that is a level of detail again, which may be confusing for some people, but a very good question. So if you look at the example of either COVID or HIV, you can have what are called antigen tests that test for the actual virus, particles of the actual virus, or you can have antibody tests that test for your body's reaction to the presence of the virus. And these are two different tests. Of course, the antigen tests have a higher level of precision because they're actually detecting the pathogen
virus
itself. Yeah.
Okay.
Yeah.
Enough about Roche. Let's talk about healthcare system.
Yes.
Okay. Many people, when you go to the basic health facility and you find a healthcare practitioner, they want to understand what it is that you have presented yourself with. Then they're able to diagnose you and know, all right, so this is what I'm dealing with and this is how I'm going to treat or manage, whatever the case. Now, many health practitioners will talk about the need to have at least some basic kits, and they don't have them. Now, let's talk about the importance of that. Of when you're trained as a doctor, you are trained on how to identify what this is. There's, that whole elimination matrix and knowing this. So how do you feel when I hit your stomach? What are you feeling? You put on the stethoscope and run it wherever on my knee. I'm kidding. And all those things. But because as a doctor, you're trained on how to diagnose, at what level do you start needing extra support in terms of machines, equipment, and others?
So I'm going to throw a couple of statistics at you, and then hopefully it'll help structure the conversation.
Okay.
This is an incredibly important conversation for me. And, when I get a platform like this, I take advantage of it and I share my thoughts. First thought, we're talking about universal health coverage in Africa. It's a noble goal. It's about time. And it is important. And I think it also underpins Africa's economic growth. It underpins Africa's economic growth because the three key areas of investment that will drive Africa out of poverty are investments in human capital. It's health, it's education, and it's agriculture. Those three. We lag far behind on those three because we don't have a good balance on the proportion of GDP that we allocate to them. We have a hugely enviable population, 1.4 billion people strong, average age 20 years. If they're educated, if they're healthy, if they're well-fed, they will not be dying in the high seas trying to cross over to Europe.
Yep.
It's a big shame for our continent. We need to stop that. So these three key areas need investment. We need to build Africa's human capital to get us out of poverty. The rest will follow. I've traveled 4 African countries just, this week. And in every single one of them, similar to Kenya, where the dollar's gone home to the US, people are struggling. The one thing that is helping the country are remissions from the diaspora. People from those countries who went abroad, they're educated, they're healthy, and they've got good jobs, they're sending money back home. A lot of African countries are now depending on this. That's human capital. Why don't we invest in the people who are here in the continent in those three key areas? Now, we're talking about health and universal health coverage. When I think about the conversation on universal health coverage, there's a bigger conversation that needs to be had, and that is on GDP budget allocation to health. In 2001, African heads of states got together in Abuja and signed a declaration saying we're going to put 15% of our GDPs to health. 15%. 20 years later, there are less than 6 countries that have done that, and none consistently. One year you hit 15, the other you don't. Most of our countries are hovering between 3 to 5% of GDP being put in health. Forget about universal health coverage with that. It's a pipe dream. It starts there if we're going to be serious. Yeah. So I'm going to build to your question, Eric, but I think it's important to get the context.
Yep.
Now, we put 3 to 5% of our GDP on health. And of that full total health budget, less than 2% goes to diagnostics. This is not unique to Africa. It's a statistic that is common across the world. Diagnostics are hugely undervalued for many reasons. When I trained as a physician in this country and started practicing, we clearly saw the lack of diagnostics. We had patients who will come in with trauma, brain trauma. Somebody has been involved in a road traffic accident. It comes in a coma, and you need to do brain surgery. They probably have a clot, a blood clot in their brain. So you need to take it out. Now, ideally, you should do a CT scan to see where the clot is before you open the person's head. We never had CT scans. Granted, we were good physicians back then, and we were trained by good physicians. And as you described, Eric, we had physicians who, purely with physical exam, they could tell you precisely where that clot is. You went in with surgery and you found the clot there, and we did it. But there's a limit to that. And those sort of physicians are few and far between today. What has happened is technology has developed. Today we have testing platforms that can give you an answer in 70% of clinical decisions that need to be made with precision. This is malaria, this is HIV, this is COVID, this is whatever it is you want to diagnose. 70% of conditions we can't diagnose for you. But we spend 2% of our health budgets on diagnostics. So there's a big gap there between leveraging technology that already exists to give precise diagnosis and letting patients, come in or suffer the consequences of lack of that. Because what happens is we end up diagnosing a lot of our diseases with the naked eye. And by the time you're doing that, it's too late. It's too expensive to treat, or you can't treat it at all. So cost to human capital. Now, my argument is that with investments in diagnostics, let's move away from the 2%, put a bit more into that, you will save on the overall health budget because you will be more precise in what you treat and you will waste your medicines less. I don't know if you've ever had the experience when you've gone to a doctor, they've sent you for a malaria test, they don't trust it, they throw it away and they say, I'm going to treat you for malaria, I'm going to cover for bacterial infection, and then this multi-therapy, right? They just throw the kitchen sink at you. That's happening right now in our country. And that is contributing to a high treatment cost. And so what happens...
And also something even more grave than that, lack of trust in the system.
Correct.
That you go to a mechanic and a mechanic tells you need to change shock absorbers and you're like, all right, let's change shock absorbers. You go to a doctor and the doctor tells you we need to treat this and you are always looking for second opinion. That is a bad thing.
It is.
Because basically you have no confidence in the health system.
can we look at, because here we are and we're looking, constantly looking for solutions to this thing. And we're saying that we need to be prescriptive, down to a T in terms of what's wrong. Treat that, let's move. At the same time, we're also saying that preventative care, obviously, is something we want to go into. Impossible to go into preventative care if your research is not up to scratch. If you don't have budgets that apply to these things, then it is almost impossible for you to do this thing. So in as much as there is an ability, there is no priority when it comes to putting health on top of the agenda, because then the very simple basic question is, what is the problem? If we know that to have societies that function, you need well-fed, healthy, educated people, it is clear. Then the simple question is, then why don't we get them?
That's a question that's above my paycheck. I see occasionally you bring politicians here and you interview them. They should tell us that, because they make the decision on how we allocate budgets. Parliament does that. But having said that, our policymakers need to be sharp on how we prioritize. And maybe they are, and, the policies that they want to put in place just don't get prioritized and therefore budgeted for. It is a conversation that needs to be had, because the world is changing, every continent is finding its space. Europe is fighting to survive. China is trying to rise. The US is fighting to survive. Africa is caught in between. Everybody knows we can be the bigger force. But up until we get these basics right, we will be, in my view, continuing to wallow in the quagmire of mediocrity as we watch other countries come and, drive our agenda. So it starts with one country, it starts with one minister, it starts with one hospital director, making the right decision and hopefully, building that opinion across the board. We need to allocate our overall budgets better and put more budget into human capital. We need to improve our budget allocation to health. And even within health, we need to plan better in terms of where we put our money to get a bigger bang for our buck. And my argument is that with the right investments in diagnostics, we're going to be more efficient or have a bigger bang for our health budget. Because diagnostics span the entire realm from giving you a diagnosis when you already have symptoms to screening you to prevent you from getting something that may be very costly to treat downstream. For example, cervical cancer or breast cancer.
Okay.
We have screening programs that other countries run. And you prevent a woman from presenting with symptoms at which stage it's too late already,
Can there be a combination? Absolutely, because essentially I don't think there's a doctor we've spoken to who has said that we are not for preventive care.
Yeah.
Every single medical practitioner says preventive care is what we would seek, because then we don't have to get into the murky waters.
But then why don't we practice it?
Exactly.
Yeah.
So now the question is, it seems though that then you're stuck, because obviously commercially it's better, quote unquote, if you then go into treatment.
Yeah.
Right? Preventative care is not as sexy as treatment.
Yeah.
It isn't, even for your pocket as well. But then here we are saying, then what role, if we're saying going to diagnostics, screening, what role does awareness play here? I will not forget a lady who sat in this chair and said there was no way she was going for cervical cancer screening because, number one, it cost too much.
Yeah.
Number two, I feel fine. Why am I going to check? Until it hit her like a ton of bricks. The pain and the stigma that was attached to now when she did get this cancer.
Right.
That is when she thought in her head, all right, I must do something. So it can be diagnostics, Dr. Pamba. We can buy the world's best machines.
Yeah.
But that awareness tag for me needs to go hand in hand with it. I don't know.
I will agree with you because it's all too often. There's a lot of things that go hand in hand. I jump at diagnostics, but it's a whole ecosystem, awareness being one of them. We are all too familiar with the graveyard of instruments that sit in the back of hospitals across Africa that were acquired without a comprehensive, fully thought through plan. And we have to avoid that. Awareness is important. Same principle applies to insurance. Why are we struggling to get people to buy health insurance, especially young people? Because I never need to go to the hospital. I'm just sinking money in there and I never benefit from it. Why should I? Until that one day when, God forbid, you are given a diagnosis that you never associated with yourself or never expected. And then you're facing huge hospital bills. And then the insurance makes sense. Not all of us will encounter that, but to the level that society is educated and made aware, to your point, that it's our collective risk as society. It is collectively protecting ourselves as society by everyone participating. When we all appreciate that, then we get higher adoption, then we get more health insurance, and then we have better budgets also to deal with disease. Similar to diagnostics, awareness is part of it. We in Africa are facing, and in Kenya are facing, a dual epidemic of disease right now. We have had infectious diseases for years.
Yeah.
We have had malaria, tuberculosis, HIV. Those were the big killers. You remember when malaria used to kill 1 million children every year, most of them below the age of 5 in Africa. That is now massively reduced. Part of the reason for it is that we have invested well and had a better balance on awareness, on diagnostic capabilities, both for diagnosing, when the disease is already there and even preventing, and on treatment. It's working fairly well, and we are turning the corner on infectious diseases as long as we keep our foot on the pedal. There's a new animal coming up called non-communicable diseases. How often do you hear so-and-so collapsed, died,
Yeah.
they had a heart attack, they had a stroke? We never used to hear that 2 or 3 decades ago. How often do you hear, so-and-so has cancer? How many of us know patients who have cancer? How common is diabetes now? So this is a new wave, non-communicable diseases. We're all at risk because Africa has the highest rate of urbanization right now. We're sending hundreds of millions of people into cities every year. And what happens when we come to cities? We meet all the risk factors for non-communicable diseases. We have inactivity. I don't know how often you guys walk around. You sit, you have to interview us when we come. We have excessive use of alcohol, exposure to tobacco. We have all these risk factors that drive non-communicable diseases. Now, what am I concerned about? Infectious diseases, we've laid out platforms and systems, and we're kind of going in the right directions. Non-communicable diseases, it's a disaster waiting to happen, if you to ask me. We are nowhere near where we need to be at this stage of the epidemiologic curve of non-communicable diseases in Africa. There's a lot that we need to accelerate. The best opportunity, if I speak honestly as an African physician, is prevention. How are we designing our cities that you're able to walk around? There are sidewalks, not just roads, but sidewalks. You're able to cycle. How are you making cycling cool and not a sign of poverty, How are we educating our kids on their choices of diet while they're young? Before they're too old like us to be able to change our ways. There are all those simple interventions, that need to be put in place now, the way we design our cities, the way we educate our children, to create an environment where we're making better choices for NCDs. I'm afraid they're not there, and I don't know if anyone is thinking about them. We often will jump to treatment when the problem is already there. We need to treat cancer. And I'm talking about diagnosis. We need to diagnose cancer. We need to diagnose diabetes, There's a lot to your point, though, which is a very important one, to do with awareness. And of course, planning here as well, multi-sectoral planning.
Which is a big thing. Let's take a break. 25 minutes to 10. Dr. Allan Pamba is the Executive Vice President at Roche Diagnostics Africa. He's here because we want to talk about the value of diagnostics in an African healthcare system and where we are at so far. This is the Friday, a Health Friday conversation. Let's take that break and then we come back.
Spice.
Dr. Allan Pamba, Executive Vice President of Roche Diagnostics Africa, the value and the place of diagnostics in our healthcare system. City?
Diagnostics, you're talking about cutting edge, you're talking about 21st century discussions. And yet, a lot of our health are antiquity issues. You're talking about fundamental, basic public health issues. Now, Dr. Pamba was trained in our university here. There's a unit that they're trained in, it's called public health. Okay? But that's not what I want to talk about. That's the unit that people avoid. They don't even think it's very important, whether they attend it or not. In fact, they don't even think it's medicine. Okay? But there's this little element of research. You wonder how many units of research are you taught? When you want to do your master's somewhere in your undergraduate, you come across it. But research as a pillar of what happens within the institution, because if it was made to be fundamental and core, the thinking of those who are trained in healthcare service, from the doctors to everybody else who's in that space, would be different. Simply because, so even when we talk about diagnostics, you'll be talking about someone who thinks differently. Why do I say this? I look at other disciplines, like say the legal fraternity, and I look at how they push their issues. They take advocacy seriously. Our friends at Afia House predominantly are people who have been trained like Dr. Pamba here. If we were to measure the skill of advocacy on a scale of 1 to 10, it would be something like a half. They don't push issues that they are the best informed about in the country. They're the ones who know these things better than anybody else. But then they let other people who are not quite as informed as them to make these decisions and push these issues. So now when you're talking about 15%, a discussion of that nature being left to these individuals, how far do you think that thing is going? How far do you think that discussion will go? Each and every discipline within medicine have something that they know and they're the experts in. The research element within those disciplines, how often do we see them even pushing that agenda? How often do they make it, or do they assume that is something that Cambridge should do? And yet, we teach these practitioners at Kenya medical training colleges and at the medical schools we have in the country. So, you, as the vice president of this huge institution, okay, you have a research and development wing, don't you?
We do.
In 1933, these guys came up. First time, vitamin C was a big issue. Roche, they came up with this understanding of how to test for vitamin C deficiency. 1933. And since then, the world has been their oyster. They've done wonderful things. Research. How much effort do you put into advocating for research within the healthcare systems on this continent? Because you work on the continent. And in the absence of research, all these things that you do, whether it is the costing of it, whether it is training people to understand these things, if one doesn't have a mindset that is focused on research, not much will be achieved. How much do you people put into it? Now that we're talking about UHC, again, in the absence of research, how far will that thing go?
It's a very valid question, CT. Quick answer, as Roche, research in Africa is very high priority. We are setting up research stations. We actually have a number of research facilities that we support right across the continent. And it's very much in the context of diversity and inclusion in medicine. Historically, now I speak as an African physician, Africa has been back-footed, to your point, on medical innovation, on the process of development of medical innovations. What do I mean by that? Historically, Africa has been a net consumer of products that have been developed in populations outside of Africa.
Yes.
And the question therefore becomes, how relevant is this dosing regimen for an African population with an African gene pool? How relevant is this test calibration for an African patient with an African gene pool? This is something Roche recognizes, and we are very inclusive in bringing African patients in our research processes. Has it always been like that? No. Is the future looking better? Yes. Why? I lead Africa now, so I have a good bird's eye view and a loud voice as well, both inside the company and outside. And I'm really pleased with the changes that I'm seeing in terms of inclusivity. There's a big project going on called the Africa Genome Project, actually, right now, which Roche is, I'm proud to say, is a partner in. And we're mapping the African genome right across the continent, creating this massive database that will inform medical innovations going forward. And all pharma companies will be interested in it. Back to your question, bringing it home. When I trained as a physician, research was not a priority.
Is it now?
It still isn't where it needs to be. So you make a very good point there. What do I see? When I was trained as a doctor, in many ways I was trained to look down. We look down, we don't look up, We see the tree, we don't see the forest, which is the public health you're talking about. It's the forest. We don't have, in this country and in this continent, a critical mass of medically trained leaders. And I use leaders deliberately because you can be a leader and then, in addition to that, have some degree of expertise that makes you a better leader and a better advocate for what you lead in. In the medical field, I feel part of the reason why we haven't reached the Abuja declaration of 15% of GDP allocation in health is we haven't led and voiced for the patient as loudly and as eloquently as other sectors have done that enjoy bigger portions of the GDP today. We need to change that going forward. And that's part of the reason why I'm here, I'd like to say.
Is there a case that can be made for partnerships with government? Usually when we talk about these PPPs, we see them as what would bring about development infrastructure. But for me, this is fundamental in terms of development infrastructure, where we say there's a realization across board, whether you're in public or private, that research is key, fundamental to then coming up, diagnostics, to then coming up with a healthy health state.
Yes.
Is there collaboration between private organizations and government within the specialists, between the specialists within those two groups? Because to start to have the conversation and to keep it bubbling, I think is fundamental to all of this.
Indeed.
That would then lead to some kind of action. But if nobody's talking to each other,
then nothing moves. Government is the steward of everything, in this case, health in the country. Government sets the path, the strategy, and then different stakeholders fall in line, and hopefully everybody plays their role, and we get universal health coverage to the extent to which we collaborate. There's a lot of siloed approaches. You've got private sector doing their thing, you've got government trying to do their thing, you've got NGOs trying to do their thing, and so on. Good effort to try and bring it together, not always successful. Where it's successful, it's magical. With respect to research in particular in this country, Kenya, KEMRI is a good example. This is a government initiative or platform on which a Roche or a GSK or any other company can latch its expertise and carry forward science collaboratively. KEMRI trains a lot of African scientists and leverages a little bit of financing from the government, and I think a lot more from external entities, be they in the industry, pharmaceutical industry, or other entities such as CDC, Gates Foundation, and so on.
Wellcome Trust.
Wellcome Trust, and so on. That is an example of collaboration. Research definitely is an area that requires collaboration, because very often a lot of the science moves thinking forward but may not necessarily give you a return on investment in terms of dollars immediately. Sometimes it's not very obvious, what you get. For example, I worked for KEMRI for a few years after qualifying as a physician, and we developed treatment algorithms for severe malaria in children. So in Kilifi, we had kids coming in the malaria season by the thousands. And we found the best algorithm to deal with a sick child coming in with certain symptoms to maximize the probability that child will survive. Now, that took research, took Wellcome Trust money, a lot of investment. And we were able to give, I think it was about a 90% probability of survival if that child with those severe symptoms stand up at that hospital, using that algorithm. Now, those children are alive today, I'm very happy to say, but nobody pays you back for the research you did to develop that algorithm. So this is collaborative effort where different entities are required to contribute and move science forward for the betterment of humanity, for building our human capital.
Bacteriacally, you do get payment for it. If you consider what implementation science does, people who began what you're doing contributed to it. Now, when something moves from research to practice, do you need a bigger reward? Because you actually see the outcome of what you started, and you see it in real time, in your lifetime, not after you have died. But I have to ask this question. When we talk of these collaborations, Wellcome Trust being the benchmark for today, does Roche have similar collaborations with institutions like that across this continent?
We do. And, it's a great question, CT. Let me leverage your question to tell you what Roche is doing for diagnostics in Africa. And I'm excited to share it because I've been with Roche for 1.5 years. What we've done with my team over the last 1.5 years is to build a 10-year strategy for Africa on diagnostics. In our strategy, we start in 2021, and we start by looking at how many tests were we supplying to the continent of Africa. We estimated about, I'll give you some numbers now, 340 million tests. It's a drop in the ocean compared to what we did globally. We did 27 billion tests globally. You know where most of those go? The US, Europe. Africa, 340 million. I estimated in 2021, we reached 50 million Africans with that number of tests. 50 million people out of a population of 1.4 billion. It's a drop in the ocean. We're just getting started. Now we've built an ambition to reach 500 million people by 2031. This is 10x. We call it the 10x strategy. So to increase the number of tests supplied to Africa tenfold in the next 10 years. It is a huge ambition. Keeps me up at night. It worries me. But I'm very confident in our continent, and I'm very confident that we will get there. Because if we get there, then we are in step with this idea of universal health coverage that we're talking about. Because we have that ambition, I have to talk about the barriers to UHC. We have to change the environment, because I'm not going to do 10x if the environment is the same. It's going to change. How are you planning to get there? There are 3 pillars to our strategy. The first one is foundational. So we're planning to make investments in key areas that are important to diagnostics. Supply chain. You saw that failing during COVID, and we couldn't get products into Africa. We need robust supply chains into Africa, be it warehousing, be it identifying places where it makes sense to manufacture certain aspects of what we do, etc. And service to maintain equipment. The second pillar is around partnerships. It's around driving access to diagnostics, leveraging partnerships. And here we are recognizing that government is key, patient groups are key, and the multiple partnerships that we're going to form. And then the third one is innovative business models. What got us where we are today will not get us where we need to be in 10 years' time. So we are thinking about really thinking out of the box on new models where we can support both the public sector and the private sector to grow this Africa's diagnostics backbone. Broadly, that's the 10x strategy. Opportune right now because 4 weeks ago, a big policy milestone was reached. The World Health Assembly, which is the decision-making forum of the WHO, passed this resolution on diagnostics for the first time ever. So this resolution opens the door to the question, why do we have 2% of the health budget going to diagnostics? We need to allocate better. This resolution means every country now needs to have a diagnostic strategy. Every country needs to define what should we diagnose at different levels of healthcare delivery. Back to Eric's question on what are the basics that we need at the lowest level. So hopefully, City, that gives you a sense of where we're going as Roche. Partnerships is key to this strategy.
It's a strong one.
It. Yeah.
Dr. Pamba, thank you very much for joining us today. Now that you're based here in Kenya, you'll keep coming.
Thank you.
Yeah, and as we gear towards the launch of universal health coverage in October, we must have these conversations
Absolutely.
before that, so we all can have all our expectations aligned.
Yeah.
Dr. Allan Pamba is the Executive Vice President of Roche Diagnostics Africa. He's been our guest this hour. Thank you for tuning in to Kenya's biggest conversation. Enjoy your weekend. See you on Monday.
This is the Situation Room, the only way to start your day.